So hi, my name is Mark Wilson, and I work with Improvement Cymru Academy with a focus on networks, but also with the training as well. If you do have any questions today, please feel free to raise a hand. I was going to ask, is everybody comfortable with Teams? But I think after the pandemic, I think everybody's an expert. So, but please do stop me and raise a hand if I don't cover anything as well as you'd like, or you're not sure on what I'm actually going through. Please feel free to stop me. Okay. I'm going to try and get this to move on. There we go. Right, so just start off by going through an agenda. Obviously, we are a little bit late starting, but we will claw that back, so that's not a problem. We do have a shortened timescale today, so we did intend to start at 10:30, and we'll be looking to close around 1 o'clock. I'll do my best not to go over, as it'll be lunchtime, and I think a lot of people will be quite hungry by then. So as we're starting off now, just to go through the agenda, we'll go through a quick icebreaker, but that'll just be to touch base and see where you are with your projects currently. And if you have any concerns, you're not so sure about anything, please again ask the questions. We'll go then into introduction from Improvement Cymru members, which will be myself then, and Michaela and Rebecca as well, just to go through some slides, some basic improvement basic slides, and consider any key project updates and things to put into your projects, as well as the aims you'd like to create. At 11:20, we're going to have 30 minutes free thinking time. So that'll be then we'll have a kind of a quiet, safe space just for you to turn your cameras and mics off. Again, feel free to ask any questions you'd like during this time, but it's just to give you that space just to look at your projects in further detail, or maybe start considering creating some aims. Then we'll reconvene at 10 to 12, and then obviously we'll go for a break for 10 minutes. When we come back, then what we'd like to do then is invite you each to then go through and discuss your project ideas and potentially some aims. And again, if you are struggling or you're not so sure at that point, that'll be a good point. Then we can obviously help you along then, or maybe suggest a few things to look at or consider. 1:45 then, when we get to that point, we'll be looking at some feedback from the course and next steps then, so what you can expect to happen after the course, what materials we'll send out to you, and hopefully when the next session will be, we'll confirm that, and then 1 o'clock we'll have session close. So we'll just move on now to the icebreaker and touching base.
Okay, thank you. So for this bit, Mark, would you be able to sort of take down the slides?
Yeah, certainly.
Thank you. And I don't know if everybody is able to come on camera. It would be really nice for us to see you all to come on camera, because you're our sort of cohort 1, and we want to know how you've been getting along. And this is your time to sort of tell us what's been happening and what you've been doing in your practice back at the ranch. So shall I go round the screen? I think that will be the easiest to do. So Nicola, you're first on my screen. So I wondered, how have you been getting on, and what have you been up to?
Okay. So I haven't really had much time to be sitting in with the doctors. I did quite a bit of it when we were still actually doing the cohort, but it's been quite busy here. So what we've done is we've decided to put a plan in place. So I've linked in with Carinos on the next course, and we've sort of asked our mentor if maybe he can do like a peer support together, so we can discuss like caseloads, and then for him to go through it with us. And then hopefully the plan is that when he gets like quite confident with us, and he's quite happy for us to start doing his clinics for him, with him supervising us, then we can help maybe future cohorts, because I know come TAF, especially in the Bridgend area, our service manager is very keen to get lots of people from different disciplines doing this course. She's very positive about it. So I think we're just trying to think of future support for future cohorts as well, because obviously there's not many mentors around, and we understand, you know, time is precious. So we're trying to think of what's sort of feasible and efficient enough. So that's what we're sort of doing at the moment.
Okay. I mean, give us a little bit of background then. How many psychiatrists have you got across CumTAF?
So in Bridgend area, we've got 2 consultants. Yeah. Unfortunately, one of our consultants was away quite a bit through personal reasons, so we've had 1 consultant really, and then we've got 3 specialty doctors, so 2 in one team and 1 in the other team, and he's been on his own because that's the one with the consultant gone. And then we've got a trainee ST4 who's new, that she just come. So she's only been here, I think, 2 weeks. And then we've got 2 junior doctors, but we've had a lot of sickness, so we haven't had many doctors in at the moment, which has obviously had a delay and a knock-on effect, really.
Yeah, so it's affected you throughout the summer, basically, hasn't it?
Yes,
Where
yes,
you could have been sitting in clinics and observing and then doing and being observed. That seems to have affected you. I'm just wondering as well, if you're thinking of this plan with, you know, Karina is coming on the next one. Karina works, does she work in Bridgend, or she?
So she's in Bridgend. So me and Karina are in the same team. We're in the primary team. We don't have a designated memory team.
No.
So it's myself, Karina, and one other colleague. So we do all of the assessments, basically. And that's been quite hard. We've been inundated, and then obviously we're acting like a crisis team. So we're realizing we've got lots of gaps in our services. So we've been linking in with other health boards who've got designated memory teams, and we're sort of trying to learn from them about where we can push our services. So that's sort of what we're trying to do.
And of course, that will be across TAF as well. Yes. So the north and, you know, sort of the TAF Ely area memory assessment as well. So I think there's a plan anyway to join all of that up, isn't there? So
I think so, yeah.
Happening.
Since we've left Swansea Bay and then gone over to TAF, they've realised we're not doing everything the same. So I think, like, Michelle works in as a designated memory team, and I think Chris Bevan, who's on the next cohort with Karina, he's also in America. So we were like, oh, well, Jen's not doing this. So we're realising where we're lacking in some service, and we're trying to learn from each other. We are.
Right, lovely. So for a roundup, then you've got a plan in place where you can try and actually get to shadow your mentors and get time with your mentors, and then for your mentors to be able to observe some of your practice, so that then you can move forward. Okay, so that will be really good, and you're going to link up with the next cohort so that you can do that in a joined up way.
Yes. Yeah. Basically.
Lovely. Thank you, Nicola. Okay. Anne-Marie? You're on mute.
Sorry, guys. I've been quite fortunate. I've had quite a bit of time with my mentor. However, you know, due to annual leave, the last couple of weeks have been a little bit sporadic. I'm due to resume again this week now, sitting in clinics with them. And we've looked at the diaries, and the outcome is that we're looking now at me actually diagnosing soon. In regards to the QI project, I've met with Sue on 2 occasions. We are collating now, we're in the research part of the project, collating the data now from each area. Sue's collating it from the GP surgeries for the dementia coding. And I'm collecting it from MAS services in Caerphilly. So we're moving forward with that. Sinead has supported a little bit with that, which is really good, because none of us have done a QI project before. So
yeah, lovely. And your QI team, I meant to ask Nicola the same thing. Your QI teams back in your health boards, have you linked in with them? Have you managed to link in with them?
The name that you gave me, I think she's moved on, because I couldn't get hold of her. So it's just finding out who
is the new one.
Yeah, the new one who's been replaced.
And you've got Rebecca Thomas, I think, in TAF Morgano as a link, haven't you?
Yeah.
Nicola. Yeah. So
I haven't linked in with her yet.
No. So that would be one of the things we'd want you to do following today.
Okay.
To link in with them. So, and I'm just wondering, I know Rebecca's looking to come in, but just to touch base with Sue, Anne-Marie, has she been able to do her shadowing sessions as well?
She's so busy. She's just inundated at the moment. So she found it really difficult, although the consultants in Caerphilly have offered. It's just that time element, you know, that she just hasn't had the time. But I think she's hoping to shadow. But like I said, you know, it's just her in as the cluster lead for the GP surgeries in Caerphilly, which is quite a big area.
So again, there's something about a joined up approach, isn't there, with the cohort and the sort of service itself, thinking about how this can actually practically happen. So I think that's really, really good. Rebecca?
So Anne-Marie, I'm really excited about your improvement project with the read codes. And are you marrying them up with the GP practice and MAS services?
That's the aim.
Lovely.
I don't know whether, you know, obviously we'll have the desired outcome, but we're hoping.
Yeah,
that we
lovely.
Good.
Okay, we'll have a good. You'll have a chance later to talk through your aim and think through your aim, and then come back and talk through your aim, so that all of us on the call can, because that's what we're here to do, to support each other and to support you in sort of firming up on your aim and where to go next with it. That'll be really good. So it'll be really interesting. Thank you, Anne-Marie. So I've got Judith next.
Hello. Put my doodad down. So we've not had very good consultant cover here, unfortunately. We should normally have 5 consultants, and we're down to 2, I think, and it's a bit patchy, and also our rooms aren't big enough to be able to have me sitting into clinics over here as well, so there's a bit of an issue there. But I'm working around it with my mentor, because she's our service manager in the memory clinic. So we're just sort of, I sit into daily MDTs and things anyway to discuss the diagnosis process, so that side of things I'm quite happy with, but it's just the feedback, so it's really working around it in a slightly different way, sort of going through what we need to do within a feedback. And I have actually got some booked in coming up in the next few weeks, which is good. So starting with sort of MCI and going from there, really. So I'm quite looking forward to that. But I'm sure I echo everybody else, but very, very, very busy, saturated busy at the moment. So I'm not very far forwards with the quality improvement, just have the general concept of what I'd like to do, but just drowning in work otherwise. So
don't worry, and I'd say that to everybody, don't worry, because this is a journey. This isn't about getting it done overnight. So the point of these 2 days, and even if we need some more, we can plan some more to actually support you through that. So that's what we're expecting really from now on in, rather than you going full pelt into it straight away. So that's good. Thank you, Judith.
Okay.
Rebecca?
Yeah, it might be that when we're listening to the people's ideas that we do similar ideas, and that's absolutely fine as well. But we're doing different similar ideas in the different regions. So yeah, let's we learn from each other.
Share and learn.
All share, all learn.
Thank you, Judith. And Steve?
Oh, okay. How are we doing? So yeah, same as everybody else. Really, really super busy. Got so much on at the moment. Manage as part of my normal day-to-day role. So I'm doing kind of backgrounds, assessments, and then taking through to MDT and providing diagnosis. So I've probably done about 4 or 5 in the last couple of months. But that's part of the normal process for us anyway, of what we normally do. I suppose from my point of view, it's just been that enhanced bit of bringing something else now to the MDT, really. But on saying that, I haven't really been had a chance to sit down with consultants as in mentoring or anything like that, simply because we've just been full chat and working through it, really. In terms of quality improvement, I did a Alzheimer's Society forum. I set one of those up about 6 or 8 weeks ago. So I managed to get a couple of service users and a couple of carers into a service, an online forum, really, just to have a discussion about what their views of the memory service were, how it worked for them, what was missing potentially. Came up with lots and lots of kind of ideas. We'd already kind of had something in the back of our heads, myself and Hayley, this is, about doing something around communication, like a communication book. So enable obviously the person living with dementia, or person under assessment, should I say, and the carer to understand where they are in terms of the process. And really, it's something. It's instilling something that's already kind of in place over in the West with Judith, to be honest. So it's not really reinventing the wheel. It's just putting it into our service. We've already got a really good process around read codes, links with GPs, the old 1000 Live feedback forms. All those sorts of things have been kind of readjusted in terms of monitoring our stats, really. And we know we're missing out a little bit over here on post-diagnostic support. And that's probably something we're going to change anyway. But again, for our service over here, because we're an assess, diagnose and discharge service really. It's looking at actually where those are the gaps going forward within the memory serve where we can provide that support. So there's a few things going around with us at the moment. It's just trying to keep on top of it and do your normal job as it goes, isn't it? That's the thing. So
yeah, it's finding the space, isn't it? And that's perhaps the smart thinking for us, is as we go forward and we get more mature in what we're doing with this course and getting buying, it's how we find that smart space, isn't it, to support innovation. And you actually, because it's a cycle, isn't it? If you can get it right and you can get it right, you will help the service, but it's actually trying to get in there to get it right for you so that it can support the service, and it's that vicious cycle.
Yeah,
Rebecca? Sorry.
Oh, sorry. Yeah, and the thing with us at the moment, we're part of such a bit, quite a big change that they're trying to instill up here.
Yeah. You're on mute.
Sorry. Yeah, we're because we're in part of a slightly bigger kind of service change up here around the old DAP funding and linking in with some of the ICF bids that were about.
Yes.
I think there's so many kind of quality improvement things going on at the moment around here that trying to keep on top of all of them has been a little bit of a challenge as well. So
yeah, thank you, Steve. Rebecca?
I was just going to say, there's some great ideas there, Steve, and everyone else on the call. Just keeping it simple. Don't overwhelm yourself with this. Just keep it really simple and really small, just to show the process. And it might be stuff that you're already doing. Like Steve, there's already doing it across BCU, and it's stuff that you can transfer, but it'd be improvement in your service. So just keep it small and simple.
And I really like the fact that you've engaged with, people who've been diagnosed and their carers as well. That's a really nice thing, and that's actually a quality improvement project in itself, isn't it? Just engaging with people who use your service, and increasing engagement with them. So that could be a quality improvement project on its own. So thank you, Steve. Janet, we come because I know you're up in BCU as well. How have you linked in, and what have you been up to?
I've had a couple of conversations with Hayley, and obviously I'm piggy banking with Hayley and Steve. We've not had an opportunity to meet up, the three of us, due to Hayley being off sick, returning back today, but we're just waiting to have the opportunity, really.
Oh, lovely. Have you managed to do any of your sessions with any
I've been to a few memory clinics, because obviously I work in Glenclwyd.
Yeah.
So I've actually got to go out to the different memory clinics. And so I've actually going to one in Llandudno and one in Rhyl. And I've got their consultants as well as my own mentor. So yes,
lovely. That's brilliant. Yeah. So you've had a chance to observe in practice then. Are you ready to move to with agreement with your mentor to go to them observing you and you having a go? Have you started that?
We've not quite started that yet due to staffing, really.
Yeah.
And me being able to be released from my job to actually go to the memory clinics. That's a problem we've got.
Yeah.
If I leave my job, I'm actually leaving us short, and we're very busy at the moment, as everybody else is.
Yeah, and the hospital care is really, it's ramping up, isn't it, everywhere, and it will have that impact on community care as well. Oh, lovely. We'll talk later then, Janet and Judith and Steve from Betsy, bringing what your projects are later on. That's lovely. Thank you. And then Rachel in Powys.
Yeah, hi, good morning. I haven't had that much luck with completing any observations due to time restraints, just with my mentor being on leave, just with clinics being cancelled. So I have managed to sit in on a few, which is positive. So we do have a plan to do some more. I've been able to review some of the case notes and some reports too. So I have a meeting with mentor this week to provide him with my reflections on that. I mean, he's very much on board, and he's very, very keen to make improvements. So that's very, very positive. I suppose it's just the challenges really of having the time to actually sometimes pin people down to meet, and he's been off as well, and so it's been a bit of a challenge, to be honest, to get some things done. I've been working with Louise on some ideas for our project. We've had a few challenges around that, which we'll talk about later. We have some ideas, but again, I think we just face a few barriers.
Okay, lovely. We'll happy to go through that later, Rachel.
Thank you.
Thank you. And then Louise.
Hello, hi.
Hello.
I did an awful lot of sitting in with a consultant earlier on. The last couple of weeks I haven't. However, we're back on track again, as from tomorrow actually. So that's all going well. I haven't done any offering diagnosis yet. I think that's actually coming next week, where we're going to someone's house. I think that's sort of my turn to do that then, if you like, if that's the right way of saying it. And what Rachel just said, we've been sort of discussing our ideas for the quality improvement project. However, our first initial idea, which we think is great, we might not be able to do because we might it just might not be able to be possible at this time, so we might have to rethink. We have got a plan B, but we, you know, obviously that's up for discussion, isn't it?
Yeah, lovely.
So,
and we'll give you some time later to think about that. And then come back on and have the discussion. And I know probably Mark is panicking about clawing back the time. So very quickly, we'll hand over to Mark, and thank you all for your updates. And, you know, I think we, in a sense, not underestimated, but actually on track with, I think, where we feel the issues and the barriers and the blocks might be, but also really, really admire the fact that you've achieved what you've achieved, because I know it's been really difficult out there. And we know the winter period is going to be more difficult than we've ever experienced before, probably. So the fact that we're getting somewhere, but this has given us really good intelligence to know, as the cohorts and this dementia, our dementia faculty is sort of growing and going forward, some of the things that you're experiencing are really going to help us establish, I think, you know, the requirement actually for taking this forward in practice, so that we can have those conversations with service leads and with you know, your psychiatry leads as well. So really, really useful. Thank you very much. So I'll hand over to Mark. He's going to take us through the basics around improvement. Some of you may already know this. Please bear with us and chip in. And some of you, it might be new to you. So we're going to take you through it and then give you some time to do some self-reflection about your projects. So thank you, Mark.
Okay. Okay, can you all see the slides?
Yeah.
I've just lost
Yes.
the camera.
Yes.
There you go. I'm back on line. Thank you very much. Yeah, again, so if you have any questions throughout, please raise a hand and I'll go into some more detail, or if you'd like to contribute or have anything you'd like to add, again, please raise your hand. We're not doing too bad for time. We're 7 minutes late starting, so we've just gone past that 7-minute mark now, so you'll be fine. Unfortunately, I think we have lost your breaks, but no, we haven't lost the break. That'll be fine. We'll have that back, so don't worry about that. And thank you to Steve as well for wearing a similar colour top to myself as well. It really gives me a confidence boost, so thank you, Steve. Okay, so heading into it. So can I just see a quick raise of hands? Who has seen the model for improvement before? Okay, Steve, yeah. Okay. No, okay, well that's a good thing then, so I won't be boring a lot of people to death here now. So again, this is going to be a high level overview as well, and apologies if I'm looking to the side, I'm just looking at the screen as I'm asking the questions. This will be gone to more depth at a later stage with Lisa Henry, who's my manager, who was hoping to be here today, but unfortunately hasn't been able to attend. And she'll go into more depth with these things and go into not just the methodology, but the tools you can use as well. So this will be a bit of a whistle stop, but I'll try and go into detail as well. So as you can see on the screen now, this is the model for improvement. And what we'll do, we'll go through each piece and break it down bit by bit. So the model for improvement is an approach to continuous improvement, just like Lean Six Sigma is, and there's obviously other methodologies, but in Public Health Wales, the main method we use is the model for improvement. And all it is a structure or a framework for approaching continuous improvement, as it suggests on the screen there. It's where changes are tested in small cycles. So it involves in what is known as PDSA. So that's planning, doing, studying, and acting. So it's just going through iterations and trials bit by bit. And as Spina said, go simple with it to start with. You don't have to go very complex, because if you add complexity, and sometimes you can have issues there. But as you go through each PDSA, you can actually then add layers or refine the process or act on changes, because not all changes will be positive. Sometimes they may not work out exactly as you intended them to. And as we kind of said already, every cycle will start with a hunch, a theory, some kind of gut feeling that there's something wrong there, or something that can be improved or changed. And that's all it needs. It's just a bit of a seed to start to try and grow the seed and develop it further. So the cycles are linked into 3 questions. The aim. So again, what are you trying to accomplish? How good do you want it? By when? Get some quantifiables in there, some time frames. So it's just really defining exactly what you're trying to achieve. Measures. Without the measures, how do we know we've improved anything? Because you say, oh no, it's going really well. It's great. It's really made a difference to the practice. But how do we know that? How can we convey that just to share learnings and say we've improved the service by 10, 12, 20%, etc. And also, not all measures will be quantifiable. Sometimes they're qualitative as well. So by just feedback from service providers or patients is just, so important just to gather that feedback and get that feeling as well. Changes. What change can we make that will result in improvement as well? So they're the 3 questions you'd want to ask, which is at the top of the pyramid on the left-hand side. So let's consider these 3 questions in greater depth. The aim, as it points out, is at the very top there, as it says, what are we trying to accomplish? So again, just a clearly defined aim, which again, we will go into in depth later on in the slides. Don't worry about that as of yet. Well, what is the aim? What does it mean? How do you structure it? That is something we'll go into later on. Okay, so as I kind of already articulated, you have a problem idea, you want to help to improve it. It's having links to what is important to your service as well. So again, clearly defining that. And you want to lead to better services, as we've already said, for your patients and service users. And at the bottom, your aim should be SMART. And that probably does link back to my contributions about SMART aims, etc. So, but we'll go into that and break that down now. So specific, measurable, achievable, importantly realistic as well. So I think sometimes we can set goals that may be a bit lofty and it can put some heads down, think, well, I haven't achieved my goals, I haven't achieved my aim, so that can be a bit unfair. So really try and consider what is realistic. And again, time bound. So you put a time on there as well. Good quote from Don Berwick. Some is not a number and soon is not a time. So again, just clearly defining those is very important. So here's an example of a SMART aim. So to reduce for the M, measurable number of falls, being specific. So in patients over the certain age range in a certain area or ward, making them achievable, as we kind of said, and realistic. So by 40%, and you may ask, how do you come to that that number or that figure? You could look at historical figures and see what has been possible over time in the past. And obviously with different approaches, maybe the further improvements can be made. But again, if aims aren't met or the percentages aren't met, it isn't the end of the world. But obviously, we'd like to understand why we didn't make that aim, and maybe go through another iteration for the PD SA. Time bound, as we said, in 6 months. And I think for myself, I've seen in the past so many projects that have kind of run and run and run, or they've had deadlines. Oh, should we just extend that? So they've had meetings. Oh, like, yeah, let's just move that by a couple of weeks, a month. If you do that, you kind of lose some of the essence of what it's about. You really want to try and honor those commitments and those time frames and get to that 6 month point and have a review. Oh, sorry, Michaela, I can see your hands raised. I
didn't want to interrupt you, but as we planned,
oh, sorry,
we're gonna ask you, the cohort today. Obviously, we can't underestimate enough the importance of really knowing your aim. Otherwise, the whole improvement and what you're trying to, you'll lose the threads of it. And it's very, very, I mean, Rebecca said earlier on, didn't she? Keep it small, keep it specific, because it's very easy for us, especially in healthcare and especially when we're really busy, to actually lose the momentum and lose the actual thread and focus. And we end up going all over the shop and we're trying to do 40 million things and maybe not achieving many of them very well, or we lose our way. We lose our focus about what our aim was about. So, Mark's starting here, and this is why the session today was put on, to actually give enough time and give the value to you being able to really nail your aim. And whenever we've done, Rebecca and I have done improvement work where we've been, like you, sitting on courses where we're trying to do improvements, this bit, I think you can't underestimate the value of this session in really helping you to think about your aim and what you're trying to achieve. So Mark has put this up here about, this is a SMART aim that has actually got everything in there. It's got how much you want to reduce something by, the percentage, it's got the time frame in there. Can anybody on the call today give some examples maybe from memory assessment services about some ideas of a name that could mirror maybe something that we've got, what we've got on the screen? Anybody got any thoughts about making this example more memory assessment specific? Have any ideas from the kinds of things you want to achieve in practice? You have 2 minutes just to think about it.
Steve, you're on mute if you were saying something then, Steve, sorry.
You're on mute, Steve.
It could be on your dongle.
It certainly is again. It's stuff like to increase the rate of read code reporting in people going through the memory service by 100%, because there's no reason why we can't in the next 6 months. So something you can make something very specific more to improve rather than reduce.
Yeah, that's definitely it. So a lot of things are about increasing something or reducing something, and you're talking about increasing the number of read codes captured within a 6-month period of people that have been diagnosed. Yeah. So that could be quite specific, couldn't it?
Yeah.
Yeah, lovely.
Louise.
Any other ideas, Louise?
Well, to reduce the time from referral to diagnosis. Obviously, that's all of our aim, isn't it? But that just in a nutshell, to use that model in front of us, from time of the referral from the individual to diagnosis.
Yeah.
Yes, and you could do that over the next 6 months, or you could do that over the next, you need to put that time frame in when you want to do it. I mean, you could even, certainly when in one of the projects I'm doing, where they've come back and said, well, would you want to go into the number of over 65s or under 65s? But you can look at that kind of thing with everything that you're trying to do. If you wanted to put drill it down even smaller. So, but when you're trying to overall increase the diagnosis, it's for the whole cohort, isn't it?
Judith.
Yeah, Judith.
Oh yeah. Sort of echoing Steve a little bit, but the quality improvement project we're hoping to do over here in the west of BCU is more around the sort of post-diagnostic intervention stuff, because that's something that we've been working on for the last 18 months here, last 2 years now, quite heavily. So I suppose it would be something more around sort of to increase the uptake within post-diagnostic interventions over the next 6 months. Something like that would be important as well, I think, within memory services. It's just wording it, isn't it, so that you're actually showing what you're trying to achieve, because I think at the moment it's quite possibly too big a concept.
And that's it, isn't it? That's the work that you do together as a team to keep drilling it down to know whether, because the post-diagnostic intervention is huge, isn't it? So you might actually want to focus it down to one element, so that's where we take you through these courses, and why linking in, I think, and learning more about improvement helps you actually focus right down. I call it the funnel. Start broad and then keep whittling it down so you come to the little spout, and then out of the end of the spout drops your perfect aim that can keep you on track.
Activity analysis.
There we are. Rebecca's just dropped that in, doing an activity analysis. Yeah. Okay, thank you, Mark. If there's no others, it's great.
Okay, yeah, no, thank you very much for your contributions there. And hopefully by the end of the session, we will get down to the bottom of the funnel and get the perfect aim out. But Now, little by little, we'll learn from each other, and like you said, we can share learnings and aims there as well. And as already been kind of said, is that possibly you can start with an overarching aim, and then from that, then some other aims can drop out then to be more specific, to then target that overall aim and feed into that. And also then at set points, you could see where you've had implementation or you've trialed something and what effect it has had for your aim. But that's where having measurables there is so important as well, that you have the right kind of data and information coming through to capture, because if you don't have that, it's going to be hard to measure or judge how you've done. So that is something to consider when you're creating your aims as well, is what measurables are available to you and at what frequency as well. So just to throw that in, I think we will go into that later on as well, but just something to consider. So click on my screen, here you go. Okay, as I just said, which is the measures. How will we know a change has been an improvement? Again, I'm not sure if you're all familiar with the term baseline, but just a line in the sand, as it were, just to understand where we are current state. Just then, when we go forward, we know then if we have made an improvement, as we've already said already. So this is about what measurements you'll take. It's a critical part of the test and implementing the changes. And also, like you've already said as well, is that it tells the team whether the changes they're making actually lead to an improvement. So it is very important going forward. Okay, so the model suggests there's two different points of measurement. First, to see if we've reached the overall project. And second, the plan section in each PDSA to see if the changes that we are making are working correctly or as we intended, etc. Again, sometimes they may not actually give you certain results that you'd expect. Maybe they'll actually create a bottleneck or constraint in another part of the system, but that's something to consider when you're carrying out your PDSAs, is that you can understand how it's impacting and how the improvement is going, just so you can actually then look at and study it and then act on that to feed into the next PDSA. So top of the pyramid is more of the outcome measures, and the PDSAs are more process measures. What that means is the outcome measure, it's to show us if we've reached the overall aim of the project. And this is done by showing the impact on the person or the systems I've just spoken about, and so to show the end result of the improvement work. Process measure, this is where we use the process measure to have confidence in the changes you've made. So you can be certain that the changes are happening and confident that the way we are moving towards our aim. So again, each iteration, each increment, you're stepping towards your aim, so you can see how you're progressing with the aims in mind. Again, the measurement over the time. So process measures record information about the changes we've made to our systems to deliver the outcome we want. Is that clear for everyone, or are there any questions around that? Again, this will be gone into more detail in the next session that comes. And I think that the following session will then include the tools you'll be looking to use as well for this kind of thing. So please don't feel overwhelmed by all this. This is just a whistle stop, so I'll go through it all. But if you do have any questions or would like more clarity, please let me know.
I was going to say that the outcome measures and the process measures, these are things that actually we go to in detail. So don't worry about too much about that area now. Okay. Mark, Lisa and the team will really take you through the tools to be able to understand what we mean by process measures and some ideas about what they are, what tools you can use, and the same with outcome measures. In the next session, there's going to be a full session on the tools you can use to actually undertake your PDSAs and do some baseline work. So that will really help you. But this is an overview today because the focus is trying to get you to the aim.
Yeah, absolutely. Thank you, Michaela. Yeah, and also there will be some material sent out after this as well, so you can look through in your own time as well, just to add some more layers to this. So, okay, as we've said, improvement takes place over time. Rome wasn't built in a day, and it doesn't happen overnight. So I think this having that clear expectation, and also as well communicating that to your patients or service partners that look, this is the start. Please don't expect it to be overnight. Obviously it will take some time, but we are on it. We're looking to go forward now. We're going to make some improvements together and look to work with them and keep them informed. I think is critical throughout. Communication is key. So seeing if an improvement is happening and it's lasting, we need to look at patterns over time, seeing the journey. And I think, as Michaela said as well, it's the journey and the story. So, and critically, I think for this too as well, is that we sustain change. But again, that's something we'll go into at a later date. Changes. So what change can we make that will result in improvement? And again, all that is on the screen is an expansion of the pyramid on the left-hand side. So it's just understanding what will make that will result in an improvement. Again, just to understand that sometimes you may have unintended consequences, but that's why we'd look to PDSA them and trial them before you go and scale and spread them. So we can have it in controlled environments and obviously not introduce any harm into the system. So this is where you select a change. So select one small change, as been mentioned by Rebecca earlier on. Go simple. Just try and start off small. Don't try and go too big with your aims. It's okay to have an overarching aim, just to understand what the big picture is. But maybe look at the smaller ones to begin with. And these ideas or theories for change may come from those who work in the system or patients. For myself, I have an aviation background, so I wouldn't dare come into your areas and try and say how you should improve your systems or look at what you should change, because I think the people that working there with the patients and the service partners, they'll know exactly where there's opportunities for improvement. And sometimes it's just small things that have been bothering you for a long time. I thought we don't have time to change this, or we don't have time to fix this. But I think this is an opportunity now to look at it and actually maybe show to other people and patients and service partners that there's value in this. And my mantra is, it's not about working harder, it's just about working smarter. And I think there's so many opportunities out there, just small little nuggets that all feed in, just little percentages that will actually add into the overall aim that you're all looking to achieve. Okay, so we've already said PDSA is again plan, do, study and act. So those are the tests of change, again, iterations. It shows 3 on the screen, but it doesn't mean you have to stick to the 3. There may be a different number of PDSAs as you go through until you get to where you want to be. And maybe start again, maybe set another point in the future to review the processes or look at if it's landing well. Again, as I've mentioned, and the usual analogy is a wedge or a chock to stop the wheel from rolling back down the hill. It's trying to get some standards in place and making sure that this change has been sustained. And this is PDSA just in a little more detail. I won't go into depth now, but I'll give you some time just to have a read of that on the screen if you'd like to know a bit more detail. Okay. Again, if you'd like to take a screen clip of this as well, please feel free to take that as well, because that's something you could just reflect on at a later date. But as it shows there, it is just a cycle. So it's just to kind of go around and go around as required. So you just plan in on what you need to do, you're doing it, you study on what comes out of it, and then you're acting on anything that you need to implement or change for the next cycle, for the next iteration. This is just a very high level. Please don't worry about the detail for the lower levels there. It's just the very top layer, just the steps involved in an improvement project. So step 1, which is the key to it, is just understanding what the problem is. And that's not so much what the symptom is. So if I kept having headaches, I take a paracetamol, but if I kept taking paracetamols and I kept having the headaches, that's a symptom. That's not the root cause. So I was really trying to think a few layers down to what is the problem? What are you trying to address? And that's when we go through the aims then to try and get to the root cause of that, or the root of that. But again, if you're not so sure about how you're going to approach your aim or how you're going to write that, please don't worry, because we will support you and we will help you out if you get stuck. Or if you want to refine your aim, if you've already got an aim, maybe you can consider going a bit further down to go down to the bottom of that funnel. But it'll take time, but we'll be there to support you. So please don't worry about that. Step 2, involve others in the improvement. Again, we don't just want the loudest voice having the opinion just to present their view on how it should be going forward, because we've seen that time and time again. Well, speaking for myself, I've seen that in improvement events. It's really involving others and gathering information, and then also validated as well. So if you have an opposing shift, engage with them as well and ask them questions like, look, would you like to be part of this? Or do you have anything to add? So I'm working on this. This isn't just my idea now. This is to go forward. Have you heard about anything of these kind of things that we could actually look to involve or include, or should we ask anyone else? Step 3, as we're going to do, is write a smart aim. Step 4, as we've already talked about, is measurement throughout the project. So possibly throughout the aims, you'll have the timeframes we'll set, then actually reconvene there and have a look at it, warts and all. Just have a look at it and see where you can improve. Just because something hasn't happened doesn't mean someone's not doing their job. Maybe there's something that just wasn't considered when the aim was first set. So that may be another point then to look at it again. And as we said, generate ideas and test the changes. That's going through with the PDSAs. Final step, reflect and identify next steps. Maybe you'll have to start again, but hopefully you've got to the end of the project there and you think that you've got the results you want.